All right. Hello, everyone. I'm Carliss Chatman, your host of Getting Common. In my day job, I'm an associate professor at Washington and Lee's Law School. The topic of today's episode is creating a pipeline for Black doctors with my guest, Dr. Cameron Matthews. We'll talk about why there's a need to diversify medicine and the efforts Cam has been working on for decades to make necessary change. I'll start by having her introduce herself. Cameron.
Thank you so much, Carliss. Yes, I'm Cameron Matthews. I am a family physician by training and currently serve as the Chief Health Officer with a company called City Block Health that I know we'll get into, that I'm so excited to be a part of, just as far as transformation in healthcare. I've really turned most of my career to focusing on vulnerable populations, underserved communities. So I started in correctional medicine, of all things, right after residency, then worked at a couple of federally qualified health centers on the west and south sides of Chicago. And then I went in and joined the leadership of Veterans Health Administration here in Washington, D.C., all before coming to City Block. But all of that just led up to really what I've been calling kind of my dream job of really being able to help figure out what this, I'll say, travesty is that we call the healthcare system is within this country, and hopefully we'll be part of the solution.
I'm curious, how has being both a lawyer and a doctor helped with like correctional medicine and veterans medicine?
Yeah, no, tremendously. And yeah, I always tend to leave that out of my bio. Actually, somebody pointed that out, that's actually not in my bio. I didn't realize that. Yeah, I really felt that I needed to get to another level beyond just clinical medicine, needed to understand more about healthcare and the governing systems in which healthcare decisions are made, whether that be at the individual patient level or by our government, who obviously loves to come into our exam rooms all the time, but we don't have to talk about that. But, you know, I purposefully wanted to get to a different scale of healthcare, and by being able to be a better advocate and hopefully work on policy, that was where I thought my role would be. So a mentor of mine steered me towards law school, my third year of medical school, and I've never looked back. In correctional medicine, I was at Cook County Jail there in Chicago, and clearly did not let any of my patients know I was a lawyer. I was not doing criminal law whatsoever, but it was really about advocating for them, about understanding kind of how to be a better voice on their behalf, just understanding, you know, a little bit, you know, from my one crim law class, because I did more con law and everything in law school. My one crim law class, I could understand a little bit more, and was able to step into a leadership role for our transgender patients there in Cook County, and was able to actually, it was a pairing between medicine and security. And I got to make decisions that actually trumped security, because I was able to take into account the needs of my patients, and sometimes that went beyond, you know, what crime they were accused of and the like. And so for me, it got me on that first sort of, ooh, I can do more than just worry about their physical health or even their mental health. I can think about their whole well-being, and that of course includes, you know, what their experience was like in the jail. At the VA, my goodness, we could do a couple hours on that. You know, I really was fortunate enough to lead our managed care office. It's called community care in VA, and that's anytime a veteran needs healthcare outside of the VA and the VA is paying for it. So was able to somehow get that office turned in the right direction, really implement this rather large piece of legislation that Congress passed and gave us 365 days to implement in 2018. So I got to pass or publish 3 federal regulations in 12 months, which is pretty much unheard of. Testified on the Hill all the time, got a lot of media sort of attention and everything. So for me, the law background just obviously it gave me a good foundation to approach, you know, legislative implementation and policy building, and then ultimately operational infrastructure, because I had to actually implement the program. But then it just got me very comfortable in being in that DC environment, in the political environment as well too. So everything was serendipitous. My whole career serendipitous. I never would have thought when I went to law school that I would have wound up doing either of those experiences, honestly.
Well, and I think it's interesting to highlight because so many doctors I talk to are concerned about liability and concerned about the line when they're advocating. And so I would imagine it is helpful to have a law degree because you know exactly where the line is, or you know how to find the line.
Exactly. And I honestly have never felt concerned about the line because in my experience, the line is your comfort level more than anything. I really have never come up against a barrier. If I'm advocating, for instance, for a procedure or some new medical treatment, maybe something that's in a clinical trial for a patient or the like, and I'm at an individual patient level, you're usually advocating for an insurance company to pay for it, right? So there, I'm never uncomfortable. In a political setting, sure, it's never really been though that, oh my goodness, I'm a physician, so I shouldn't be saying this. It was really more that I was representing the federal government for a good 5 years, and I had to, obey the Hatch Act and make sure I wasn't going outside of my space. But now, I'm nice and loud on LinkedIn, as you probably see.
Yes. Now she is free. So
now I'm free.
So she's free to tell us, I always say that we bring all of our identities. I bring my identity into the classroom. You bring your identity to work with you, into the exam room when you're advocating for patients. So I'd like to set the stage by first talking about why is it even necessary to diversify medicine?
My goodness. It's such an important question, and one that I like to say goes way beyond maybe in other fields. It's maybe leaning more on kind of the ethical feel good sort of argument, right? We should be diversifying because it's the right thing to do, right? It actually goes way beyond that in healthcare. In healthcare, we have the evidence, the data has been shown time and time and time again that actually when you diversify the clinical team, you're actually meeting the needs of patients and therefore improving health outcomes. So there's an actual purposeful approach to health equity when you're diversifying medicine. There's the description we call it is racial concordance between the physician and the patient actually leads to increased levels of trust, increased communication, increased adherence to treatment plans. And so because the patients feel more connected to us just outright, they're more likely going to work with us to hopefully achieve that sort of shared decision making as well as desired outcomes. So diversifying medicine is hands down not even the argument anymore, whether or not we should do it. It's really more so whether or not these health systems, these universities, all of these structures out here are willing to put the resources behind actually making the difference from a structural standpoint, from an institutional standpoint.
Now, I'm curious to know what the numbers are like. I live in Charlottesville, Virginia, and it is virtually impossible to find a Black doctor here. Or, almost any doctor of color here. It's really, really hard. And so, I'm in a rural part of Virginia. I'm sure urban areas are different, or are they? Like, what are the numbers like of Black doctors?
Definitely easier in urban areas, but it's still pretty depressing, I would say. For African American physicians, we're about 5% still. That hasn't really been fluctuating. For our Latino and Latina brethren, they're more at the 5.8, just shy of 6%. So not ridiculous, but on an upward swing, much more larger areas of growth, particularly in certain states, than we're seeing for Black physicians. And then, my goodness, we don't even need to talk about how we're not even close to the 1% for Native Americans. So those three areas are what are considered, those three communities are what's considered underrepresented in minorities. So not all minorities are what's considered diversity in medicine, because we do have a fair amount of Asian physicians and Middle Eastern physicians and of course others. So it's really about African American, Latino, and Native American that we focus on when we talk about diversity in medicine.
Well, and I always
from a race and ethnicity standpoint, right? There's other forms of diversity, but race and ethnicity at least. Yeah.
Well, and I think it's important to point out, when we're talking about 5% for African Americans, approaching 6% for Latinx and Latino, we're talking about 25-30% of the population represented by 10 to 12% of physicians. So there's a big disparity. So even being in a city, that doesn't mean that it is easier to find a physician who looks like you and understands you.
Completely. Completely. And it's really not a data point that is easily accessible for the average patient. I would think maybe some of us who have gone to such illustrious universities as you and I did, where we have, alumni connections and friends, and you can ask around. But then when I think of some of my patients who have absolutely no connection to any friends or family members in healthcare, and they have no idea how to even start that question. How do you find a Black doc? I mean, there's Facebook groups and there's a lot of ways to connect, but then when you get down to the nitty gritty of finding a doc that you need in a specialty that you need, that can help you, maybe with your condition or your concern that you need, it gets even more difficult, definitely.
Absolutely.
I think the one good thing I'll put a shout out on, there are a couple of good startups out there that are really trying to create directories of us, and particularly for Black females. There's a couple that I'm really proud of that are starting to get a lot of people's attention about really making sure that we're accessible to communities. But there's still few and far between.
So how about the number of Black students pursuing STEM and doing what it takes to get into med school? Has that number changed at all, or are we still seeing a deficit?
I wish I could give you an exact number. I'll say kind of anecdotally from my exposure of talking to students, of at least being somewhat connected to kind of education. I'm not necessarily seeing increased numbers interested in STEM. There is some evidence of increased numbers of both Black and Brown communities interested in going into medicine, public health, and that's actually due to, or maybe not a causal relationship, but through the COVID pandemic, there's been increased numbers of students applying to public health degrees, medical school from Black and Brown communities. And in my mind, that's because they're seeing the evidence right in front of them, right? They felt it through their families, how they've interacted with the healthcare system, felt the inequities, but now they're actually recognizing they can do something about it. And that they're needed. So I was so proud to see those numbers. There were a couple articles last year that really highlighted that. So increased numbers, but nowhere near enough getting accepted, actually matriculating. And then of course we need to talk about being retained and actually graduating. So yeah, we're not there yet.
I saw an article recently that said that there were fewer Black men in med school now than there were 20 years ago. And that the numbers in some areas for med school specifically are declining. Is that true across the board with communities of color, or is it like a Black male specific thing?
It's a Black male specific thing. Unfortunately, Black females, we've seen increased numbers, but Black males dropped off. I forget what year it was. I think it was maybe the late 20-teens or mid 20-teens. There were only 100 Black men matriculating in med school that entering year. I mean, it was something abominable. That was the bottom, hopefully, of the curve. Hopefully it won't dip even more. But no, it's atrocious. I mean, there's very little support. There's very, I think, minimal resources when you really think about the pathway into medicine. This is a marathon, right? To be able to have, as your question was, to have the background in STEM, to really be able to then proceed, through an undergraduate career that has the good mentoring and science background to actually get you, on a path into medical school. If indeed you go straight to that 4-year school, right? So many of our students are needing to go to other degrees, maybe even go into military service and take some time and really have what's considered a non-traditional path before they consider medicine. There's very little support for those students that are not focused at that typical 4-year college experience, and then medical schools really don't reach out beyond their traditional areas of recruitment. So the support of really making sure not only that they have the science and the mentoring, but the test taking skills necessary, the interviewing skills necessary, time management skills. I mean, this is a holistic set of skills that need to be developed that unfortunately a lot of our students don't receive either in home or in their schools. And that's a travesty.
So is this a thing just with med school, or is it with all health professionals, right? Are we seeing declines in nurses and nurse practitioners and physical therapists, or is it kind of just at the top?
It is definitely still a problem in the other healthcare fields. I would definitely say it's probably just because of the length of a course into medicine. It's definitely more difficult. And a lot of students, unfortunately, look at these other healthcare fields, which are just as critical, but they look at it as their second choice, right? So if I can't get into medicine, I'm going to consider one of these other paths. So at least there's those other opportunities where they can, be caught hopefully and supported and mentored to stay in other fields. But for medicine, unfortunately, there isn't a second choice. Either you make it or you don't. Yeah, I would say, I can't quote you the numbers, but I would say that the numbers are worse in medicine. Dentistry, pharmacy, still very difficult. We actually, in my nonprofit work, we actually include these other fields, and it is just as difficult to when you're looking at the numbers of us matriculating into schools, and we are just as equally needed across the entire healthcare team because we all serve a role. So I think that's one of the hard pieces, especially when you're talking about these schools that maybe don't have the right, again, guidance counselors and preparation for students to really aim into healthcare. They don't even have the exposure that there's many other healthcare fields that they could be even looking at, that they should be considering. Because again, they just don't have that bandwidth, unfortunately, in those schools to make sure that students are exposed.
Now let's get into some specific programs you've been involved in over the years and your nonprofit work. Could you tell us what the Tour for Diversity in Medicine is? And also like what motivated you to start this organization or be a part of the start of it?
Yeah. So the tour, as we call it, was kind of a love of mine that I really have been pushing at. I'm thinking back to years now. Back to 2005 was when we originally came up with the idea. My friend and I we founded this idea after working in another student organization, kind of like BALSA in law school. We got the Student National Medical School in medicine, and Student National Medical Association, SNMA, and we were both national officers, and really realized that so much of the recruitment, so much of the pre-med focus that we did in SNMA was around medical schools because we were all medical students, and so our bandwidth again was pretty narrow as far as how much time we had or what students we could reach. And we really started thinking to ourselves, if we're going to diversify healthcare, we need to go out and find these students. They're not going to be seeking us out. If we're going to diversify healthcare, we need to introduce healthcare to those areas, like I just mentioned, where it's not even considered an option, where there is no mentoring. They don't maybe even have a hospital where there could be exposure or mentoring. And so we decided one night on the phone, and yes, there were drinks involved. We were like, we should just get on the bus. We should just go find these students. And that's literally how the idea got formed. We didn't start traveling because we didn't have funding or didn't know what we were doing for another 7 years or so. So our first trip down through the South was in 2012. And so we've been traveling the country now for 10 years. We've been to 27 states. We've had more than 3,500 students in our in-person programming, and then more than 5,000 or so in all of our virtual programming. And the idea is you can't be what you can't see, right? I keep emphasizing the mentoring piece. If all you see is somebody like a Dr. Cosby, right? Like, my goodness, that's like the worst choice now, right? But if that's the only option that you see of a doctor that maybe looks like someone like you, right? And there's really no connection to your reality, how would I even consider being that, right? It's the same in law. It's the same in a lot of our fields, right? You can't be what you can't see. You need to have someone in front of you as a role model, as a mentor, and someone that can connect with you, someone not just on a screen more than anything. So with the tour, we bring about maybe 10 to 14 Black and brown docs, dentists, pharmacists, young, like, hopefully, well, I was young at one point, but young and enough so that our students can connect with them. And we talk to high school and college students around the country and just motivate them, try to give them the real deal that we're not perfect. A couple of us failed out of college. We didn't score well on our MCAT tests and even SATs at all, many of us. Mentors told us, no, you couldn't do it. No, it's not possible. No, you're not smart enough. But yet we're all practicing, and here we are, that they need to see that medicine, dentistry, and pharmacy is an option. So we've had fun with it. It's my passion. It's what fills up my evening hours outside of my regular work, but it's worth it.
It's interesting when I think about, you gave the Cosby Show example, which has not aged well. But I think about when we were kids, we had Ben Carson. Like I remember when Ben Carson came to my high school, or no, it was middle school actually. Ben Carson came to our middle school. We all read Gifted Hands. We all wanted to be brain surgeon. I was like, I could be a brain surgeon like Ben Carson, or in law, it was like I could be like Thurgood Marshall, right? Was the example for years, but we really, really only had those one or two examples that were on TV or that were, it was like Ben Carson was a god to us for a while, right? Yeah. But it was like, oh my God. But I think what was so appealing about Ben Carson's narrative was, grew up in a single parent home, grew up poor. And it was like, wait, if he could do it, everybody can do it, was how we felt. But we don't have that modern example anymore. So I think what you are doing is so important, because I can't think of who is the doctor that the kids now look to other than you and your tour.
Yeah. I mean, there's a lot of pipeline programs like ours across the country. And I love, we don't look at, none of that can be competitive, right? We're all necessary. We all need to reach students in our communities and the like. I think we have had the fortune of having some great attention, some great acknowledgement, and have kind of a national push. So I love that we're just going to keep doing this. We're hoping to get to the Midwest, Illinois, Wisconsin, hopefully mid 2023, late spring, mid 2023, and then just keep traveling. Our goal is to get to all the 50 states and just recording and coming up with more content, expanding our workshops. Like a lot of what we did, again, virtually through the pandemic was try to answer a lot of students' questions. And we ended up turning those into workshops. So what was it like to practice medicine during COVID-19? Why was it so important that we were there as opposed to some of our other colleagues? Like, how do you even think about race and ethnicity in medicine in something like the pandemic, in a public health emergency like that? And so we had those very frank conversations. We talk about cultural competence, cultural humility, where yes, it's important to diversify the workforce, that you need to have that racial concordance, but at the same time, we're not releasing our colleagues from their accountability either, that every single person within healthcare needs to understand what it is to be humble in the face of someone's identity, and that you need to have your own sense of really humbleness to be able to work with patients. It's a very private relationship. It's one based on trust, and without that humbleness of understanding your own culture, how you define it, and then how you may project and hopefully prevent that projection in the future to the patients that you're treating. That's so critical. And so all of our colleagues need that. So we start these workshops, we start really just pulling students in as early as possible. We even have had some junior high students come into our workshops and just really ask great questions. They are so smart and have a real focus on, I think because they've been through experiences over these past couple of years, a real focus on what they need, what their families need. And so hopefully our programming has given them some insight and the motivation, because we laugh, we joke around, like they also need to know we're real people, right? And that we have families, and that we were just as devastated during the pandemic, and that we have behavioral health issues as well. We talk very frankly about how most of us are in therapy. We've got debt, we're paying our bills off, like all of their concerns that may come to mind when they go into medicine or when they hear about the difficulty and everything, we're very open and honest about, because we need them to understand, yes, we're human, but yes, it's possible.
Now, let's say it's a prospective med student who's, out in the middle of nowhere and, does not have the guidance, counseling, and mentoring and support. How can they find out more about the tour?
Yeah, we are all over social media. I think we are having a lot of fun with it. We're still not on TikTok. I think we're trying to figure out how to get on there, but we're all over Instagram and Twitter and Facebook, although nobody really uses that one anymore. But we're doing as much as possible to post content, even kind of live, IG live sort of events where we just interview each other and try to share our stories and the like. So most of our programming now is just highlighted on our social media. So if students just follow at Tour for Diversity, and it's the number 4, Tour for Diversity. We're everywhere. You can find us. And like I said, we'll start getting in person again. We'll get back on the bus. That's what we keep saying. We're going to get back on the bus hopefully in 2023, obviously for other reasons and financial reasons. It's expensive to get around the country, and
Yeah.
fundraising is not exactly my favorite thing to do. So we're going to get back on that bus as soon as we can. But until then, we're reaching more and more students, even globally, through our virtual programs. So we'll keep doing that.
I'd like to go backwards a little bit and talk about what it takes to get into medical school. What should, you mentioned middle school. And I remember when I was in middle school, we kind of had counselors, even when I was in middle school, who said, if you think you want to go to med school, you need to try to take algebra in middle school. And you need to try to make sure that you've gotten through like physics in high school. And so I had someone saying that to me in the 6th grade. I know not everyone has that. I was at a G&T middle school, so it was leveled up and a little bit intense. But, for people who are not at an intense middle school or high school, for optimal preparation, what should they be doing in high school? What should they be doing in college to be medical school ready?
Yeah. I think the one thing I'll emphasize is there's no single path into medicine. And it's been shown time and time again that the non-traditional is becoming more traditional, in the sense that we've got plenty of students who may not come from the school, like you mentioned, that had the ability to have algebra and even calculus by the time you get to high school, those sciences and everything. Maybe you can't even afford, maybe it's not the school you had, the classes that you have available, but you can't afford to get into that 4-year college. And so maybe you need to think about a junior college, a community college, things like that. All of that is possible to go into medical school. So it's really not so much about what do you need to do when, it's just how are you going to get that coursework in at some point, right? So we have plenty of students who have been through community college, maybe even have a full associate's degree, end up going back to 4-year college, taking their sciences, and then getting obviously prepared through the MCAT and the like to get into medical school. It's actually an increasing age. When you look at the matriculating students into medical school, the average age has been increasing. So more students have been coming in through a non-traditional path, where they either took time off after college, didn't go to college right away, and the like. So in high school, yes, you should aim for as high and rigorous of coursework as possible. So getting up through algebra and calculus is usually something, not because you need calculus whatsoever. My goodness, no one uses that in the actual practice of medicine. But it's because of the level of rigor that calculus to then get you to physics, to then get you to the upper level sciences, that you will definitely need in college. Unfortunately, the college coursework is quite robust as far as the set of requirements, but specific majors are not required. I was a public policy major, so I was pretty much on the path going to law school anyway early on. But it's really about having that physics, having that organic chemistry, having that biology, having basic chemistry, having a year of calculus in college. And then some schools require biochemistry. So if you're thinking of that coursework in college, you definitely need to have those upper level math and science classes in high school in order to get there. Now, again, if you did not do that in high school, if you can't do that right now, it is possible to just proceed through the classes that you can get to in college, and then do what's called a post-baccalaureate program, a postbac program, where you're taking those upper level college classes in either sometimes a degree program or just coursework after you've already gotten your college degree. Those count towards medical schools. And postbac programs also have a lot of other support and mentoring to actually get you ready for medical school as well. So there's a lot of options. We talk to students all the time that are worried about doing things at the right time. It's not about the right time when you take a class, it's about the right time when you're going to be prepared enough to really be able to absorb that information. And then hopefully do well in the coursework enough so that you'll be prepared for the MCAT, and then of course prepared for medical school.
And I'd like to emphasize what you said about postbacs. I also have friends who did masters. I have friends who were like me in English majors in college. I was like English and AFAM studies. I took no science. I took calculus, but I wasn't taking real science. And I know of people who were like me who took no real science in college and either did like a master's in public health and made sure they did the hard sciences, or they did a postbac program and did the the upper level science and math that they needed, and then went on to med school. And I think it's important to emphasize, like, the door is not closed because you quote unquote did something wrong. There is no doing things wrong.
There is no doing things wrong completely. I think that's one of the more frustrating pieces about our kind of pre-med path typically, is that there's a lot of advisors that want students to stay on a very traditional path. There's a lot more that are more flexible and really will help the students. But it's definitely difficult once you've graduated from college, because a lot of times our students don't know how to find that advising, right? They're no longer connected to campus. Maybe they haven't been successful in getting into a postbac program. So there are plenty of online resources. We do a lot on the tour to try to reach those non-traditional students as well. But again, when we're thinking about who we need in the healthcare workforce, who I need to be a doctor, I'd rather have someone that has other experiences, maybe needed to work through college, maybe needed to go into a whole nother career to then come back and know that this is what they want to do and how they're going to help their patients. Those are the physicians that we need to help our communities, to be honest, especially if they look like our communities, but more importantly, that they have experiences that can be really applicable. So I actually love helping the non-traditional students because I think they're going to be stronger once they get into medicine.
I agree. And I should say too, I know that there are some post-bac programs, people wondering, well, how do we pay for this? You know, with the student loan debt crisis, there are post-bac programs out there geared towards students of color that pay for tuition, or that give stipends, or that give the support that you need to. So don't think that you're going to spend hundreds of thousands of dollars anymore before you get to med school.
No, that's exactly it. There's a lot of support out there. It's about, having the initiative to ask around and find those questions, and to get creative with kind of scholarship work, to really think through and hopefully be wise around loan repayment as well too. As much as that is a difficult and stressful piece, I also want our students to be smarter about it, and to be aware that, like, I'm still paying off my debt. Most of us are. Sometimes it's just not possible to go through. So I don't want students to be afraid of that and turn down an opportunity just because they're scared of what school loans might bring them. It's difficult for a lot of students to understand kind of the weight of that debt. So I do a lot of talking with students about what it means and how it looks in the long term and everything.
Yes, I am still paying. I may never finish paying my loans. There are moments when I'm like,
I really don't want to be honest. It's the best interest you'll ever get. That's my whole thing. Why would I rush to pay this off? I'm going to put money into real estate more than I'm going to pay off my loans. That's how I look at it.
Exactly. I do the same. Like, whenever someone's like, I paid off all my loans, why are they doing loan forgiveness? I often say, why'd you pay off all your loans? If you had a 2% interest rate, I understand that people younger than us have higher interest rates, but if you graduated when we graduated, it is still the lowest interest rate I have ever had in my life. So
I will hold these until the end.
Exactly.
Yeah.
Now I'd like to get into some of the other work that you've done to improve healthcare outcomes and your current employer, City Block Health. So what is it that City Block Health does?
So City Block is a transformative healthcare practice. We provide integrated primary care and behavioral health and actual social care for Medicaid and dual eligible programs. So dual eligible means Medicaid and Medicare. So those low income seniors, which is Medicare. It's a value-based practice in the sense that we are not paying for care in the traditional methods, which is what's called fee for service. So when you go see a doctor now, your doctor gets paid for that visit. If you go get admitted to the hospital, that hospital and the doctors that you see gets paid for that bed for every night that you're in there, or every visit that the doctor comes in and makes to you. They build essentially when you're sick. If you weren't sick, you wouldn't be coming in. If you didn't need to get hospitalized, meaning you had a difficult enough problem, then they wouldn't get paid. And so for a lot of us, we see that as misaligned incentives. The healthcare system shouldn't be based on the fact that patients need to remain sick for the business model to work. So instead, with value-based care, the concept is that we are focusing more on outcomes for patients. We'd rather get paid when you are well. We'd rather get paid when we're improving your healthcare. So what we do from a business model standpoint is we arrange with your health insurance company, with particular health insurance companies, not all of them yet, but we arrange to accept what's called risk. So sort of insurance risk. And we are managing our patients more to keep them healthy, to keep them out of the hospital. So we're trying to decrease the costs for these patients while also improve their health outcomes. And so the incentives are in line. So it's aligned. So it's based on value. And it's based most importantly on their experience. Our company, obviously, in focusing on Medicaid and low-income Medicare, we are treating probably 70-some% of our patients are from Black and Brown communities. We purposefully, therefore, have care teams that are upwards of 70% Black and Brown. And so we're focused on health equity. We're focused on making sure that we're meeting their needs, not just from a physical health standpoint, but like I said, with social care. So I'm going to worry about and be able to pay for if they need food because they have food insecurity, if they have difficulty with housing or transportation or broadband access and the like, because all of that impacts healthcare. Those social determinants of health are unfortunately not something that the traditional healthcare system can pay for. They screen for it, they refer patients out, oh, you need to get this addressed because it's impacting your healthcare, but they're not able to do anything about it. In our practice, we are able to do that. We're able to support our patients fully. So I find it refreshing to step away from the rest of healthcare and really think about how we're going to improve and transform healthcare in a different type of care model, a different type of business model more than anything.
So are y'all like, because I think about like, I basically feel like I serve as my parents' healthcare concierge as they've gotten older, right? With like, trying to coordinate their doctor's visits and trying to coordinate testing and when they have surgery and their deductibles and, making sure they've signed up for all the right types of insurance. Are y'all doing that as well for these low income patients?
We do a fair amount of that, yes. So we are there to coordinate their care, to connect the dots, navigate them to their different specialists. Sometimes we're also their primary care. So we're a primary care practice. So sometimes we're their doctor, but sometimes we're not. Sometimes they stay with their primary care doc in the community. So we will work with their primary care practice and maybe fill in the gaps that primary care practice can't provide. So for instance, most primary care practices aren't integrated with behavioral health. So we have psychiatry, psychology, everything in our practice. So we'll provide that to the patients. We also have clinical pharmacy programs. Typically in our communities, the only pharmacists you see are the pharmacists that are dispensing meds, right, at the corner pharmacy. I'm talking about clinical pharmacists that are helping us with our patients, are actually part of the care team, educating the patients, making sure they're on the right dosages, using the right medicines in the first place, just really optimizing medication management. That's part of our care team as well. We have palliative care. We're doing the work for social determinants, like we said, because again, the average primary care practice can't do anything about if you have poor housing, right? They really can't do anything if your lights get turned off. We're actually going to be able to help with that. So we see ourselves as kind of, it's probably hard to think about, but we're filling in all the holes that the rest of the healthcare system either can't do something about, aren't getting paid for, or unfortunately, it just doesn't exist because no one's really there with you. Once you leave your primary care's office and need to go to the specialist or need to go to the ED, you don't really have someone in the healthcare system like yourself, Carliss, like you said, that you're kind of helping your parents and filling out paperwork and doing everything. There's not anybody else by your side to do that. So we can do that, but we can also do a lot of your medical care.
I'd like to go back to behavioral health because I think a lot of people do not realize that both traditional health insurance and Medicare and Medicaid can pay for counseling services, for psychological care. So could you let folks know, what kind of services people who are on Medicare and Medicaid have access to?
They have access to all of really the evidence-based care that they would need. But let me caveat that access, meaning it can be paid for through the programs of either Medicaid or Medicare. Access, meaning that there's actually someone available in your community that's going to take that Medicaid That's the difficult part. Unfortunately, a lot of, there's a lot of a capacity issue, as we've seen during the pandemic. It's pretty much hard to find therapists, psychiatrists, psychologists who are, taking new patients nowadays, because their practices are just filled to the brim. There's not enough of them graduating, point blank, let alone if we're talking about Black and brown communities, right? Just in general, there's not enough behavioral health workforce. So one, capacity is low there, so access is limited. But then two, the number that are actually taking Medicaid, so many of them take out of pocket, like do not take insurance, because unfortunately Medicaid and Medicare do not pay as well. And so a lot of these practices end up limiting or excluding completely how they're treating Medicaid communities. So while it's available through the programs, a lot of our communities still have difficulty accessing, not only because there's not that capacity like I just described, but a lot of the kind of cultural competence around how they're actually treating our patients that are traumatized through any number of issues that they're facing in their communities. A lot of our patients, unfortunately, are facing substance use disorder and a lot of other things that low-income communities are unfortunately facing without having the ability to then find treatment easily. I mean, if you're wealthy and you have a substance use disorder, you can go to a rehab center at the drop of a hat, right? There's always going to be somewhere you can go find treatment. Those are not as available in our communities because, again, the payment by insurance companies is not as good. So they're not looking to help our communities because it's not a business model that meets their needs, unfortunately. So we're trying to do as much as possible in City Block. That's why we offer it as part of our practice. We don't want you to have to go seek out where these therapists and rehab programs and the like are. We offer all of that treatment within our practice ourselves, as well as your primary care, as well as hopefully helping you with other social needs. So we're trying to be that one-stop shop.
I have a lot of international listeners who are probably totally confused about why your business is even necessary in a US healthcare system. So I would love for you to just, as briefly as you can, explain why. I'm sure you could write a dissertation on this, right? Like, why is a business like yours even necessary? If we've got this public health kind of system with Medicare and Medicaid that's supposed to be a safety net for people and supposed to service the elderly, how is a service like yours even necessary in our healthcare system?
Yeah, I think the complexity of our healthcare system and the lack of, I'll call it kind of interoperability of all the pieces of our healthcare system is really where a practice like mine that really seeks to coordinate services for patients, it becomes necessary. So you could have a primary care practice, sure, that takes Medicaid. The federally qualified health centers that I mentioned that they used to work at in Chicago, that's a huge set of practices across the country that really focuses on both Medicaid and uninsured patients. They really do take care of low-income communities around the country. You could have that practice, but that practice may have real difficulty, again, having capacity for behavioral health. They probably don't have a pharmacist. They probably don't in any sort of way have the ability to help you figure out how you're going to, get your next meal or afford your next housing and things like that. A lot of FQHCs do a lot of work as much as possible. But again, they're often short-staffed with that sort of social work, that sort of social care that their patients need, because the payment structure for most of the healthcare system within the US is, again, that fee for service. So as much as they want to connect the dots and coordinate and have a nurse navigate patients, do all this stuff, they don't get paid for that. All they get paid for is that doctor's visit. So the emphasis is 100% on increasing that productivity, that doctor productivity, or a nurse practitioner or a physician assistant. It depends on the state. It depends on everything. But there's no payment structure out there for all of these other services, that kind of concierge, that kind of navigation that you said you're doing yourself, Carliss. There's no payment structure for that. So it's not emphasized. So hospitals don't offer it because once the patient gets discharged, it's not my responsibility anymore. It's frustrating. We are so necessary because no one's connecting the dots. And then, oh my goodness, we don't have to talk about the fact, because we're all different healthcare systems, we're all on different electronic health records. So the data doesn't pass between hospitals and practices and specialty offices and emergency departments. So the patient is stuck with sharing the information between all of that. We're just a completely disconnected system. So yes, there's these public programs, but it doesn't really dig into how the actual healthcare is being delivered.
Absolutely. And every time I talk to someone in Europe, they're like, what? They're like, this doesn't make sense at all. Like you have a public health system. Like, why are people still sick? Why are people, lacking care? Why can you only really get treated when you go to the hospital in the US? And so I think, there's this disconnect, and we also have 50 states, so we can have 50 different forms of payment and 50 different healthcare systems. So it makes it just very, very difficult.
Yeah. I'll also say that the other big piece, and what we're, clearly as a primary care practice really emphasizing is, as a nation, our healthcare system really doesn't emphasize the importance of primary care. We're pretty much a tertiary care healthcare system, which is, like you just said, when you get sick, you can go to the doctor, but there's really no emphasis. We don't pay enough. We don't train enough primary care practices so that you have someone who is advocating for you, who is worried about preventing you from getting sick in the first place, about knowing you, about having that continuity relationship, about hopefully being that, first step into healthcare. The average patient in this country doesn't have a primary care doc, and they're often going to the emergency department when they need something that could really be taken care of in a primary care setting. At least my friends in other countries, the largest difference is just our emphasis on these big hospitals, these tons of surgeries and fancy specialists and the like, when really the average patient just needs a good primary care doc.
Yeah, I always say in my 20s, I used urgent care as my primary care doctor, in part because I didn't have time, right? So if I got strep throat, or it was just like, I got time to go to urgent care, especially when I was practicing law. I have time to go to urgent care at midnight. And that's what I have time to do.
And that's the thing. I'll take that on. No, in primary care, that's one of the things that I think is absolutely unacceptable, that primary care practices still work on like this 9 to 5, maybe an occasional evening. Like, our patients need us available evenings and weekends, especially when I'm talking about low income communities where they often don't have PTO, right? They can't take medical leave in any sort of way. They're having to leave their job, sometimes multiple jobs, to come to the doctor's office to sit in there just for 15 minutes. That's ridiculous. It's actually, I would say, causing increased stress in every sort of way, and really threatening their well-being by expecting them to step away from their jobs to come in to see us. Why don't we offer more? We should be offering more evenings, weekends. That's why urgent care has jumped up, because basically our patients are voting with their feet. They're not coming to primary care because we're not available for them.
Yeah. Well, and I always think about stuff whenever I go to the doctor. Here in Charlottesville, it is free to park at the doctor's office, which was revolutionary to me, because in Houston, I remember like it could be $40 or $50 to park to go to the doctor's office.
Yes. Huge issue throughout the VA as well too. I remember the parking spot dilemma at some of our medical centers around the country. Yeah, it's a huge problem. It's a barrier to care. We need to decrease all barriers to care, instead of finding a way to shift the responsibility, the cost to our patients. We've really, unfortunately, done that a great deal.
All right. So now, how can people sign up for your services if they want to join City Block Health or have City Block managing their healthcare?
Unfortunately, we're not open enrollment. So we only take patients from specific health insurance companies that we have contracts with. So currently we're in New York, DC, North Carolina, Connecticut, Massachusetts, Ohio, and Indiana just opened in the past couple of weeks. And we've got a couple of more states opening up. So if we are available to you, actually, we'll call you. Don't worry about finding us. We are reaching out to every single member that is assigned to us through the insurance partners that we have, because it's our responsibility. We are accountable for these patients. So when you hear about City Block, please stay on the line and find out more, because a lot of our patients, need to learn more about us before they recognize really what benefit we're able to provide.
And I just want to emphasize that, right? Because I think, again, I help manage my parents' lives now as they've gotten older. There are so many robocalls from scams, I think, for people who are on Medicare, right? There's so many. City Block is one of those places that is not a scam, right?
We are not a scam.
Right,
Yes.
right. And I think it would help, how can patients or people know when they're getting a call that is real? Are y'all asking for people's social security numbers on the phone? Like, what kind of content? Yeah.
No, not at all. So we're actually preceding all phone calls with mailings from their health insurance company. So you actually, and it'll have our logo along with their health insurance company. Um, and you'll have information there saying that we're calling. We're usually going to reach out by text message as well as phone calls. So you're going to have a couple of different options to communicate with us. We also offer, virtual calls, at home visits, actually. So that's the one thing that we're really quite proud of. We are not just an office visit where, again, we're expecting people to come to us. In all of our markets, we offer home visits where we're actually going to come and meet you and answer your questions and take care of your needs. I have a lot of patients, particularly here in DC, that really feel uncomfortable with the home visit. We're meeting them on park benches and we're just having conversations with them. We have a mobile van. We park it at different places, kind of in Southeast and Northeast, and our patients come meet us at the mobile van and the like. So we're doing different ways, different marketing as well. We just released a new logo in the past couple of weeks and everything. We want people to see City Block and know us more. But we definitely are a partner with insurance companies and definitely would not ask for any information without you having more comfort level about who we are and why we're calling.
Absolutely. And I think, it's important just generally to know when someone is legitimate business, they're going to identify themselves and they're going to identify themselves properly. It's when someone is scamming you, they give you no info, right? So just take note of that when you're getting calls, if you are on Medicare or Medicaid. If someone starts the call by asking you for lots of information, it is probably not a legitimate business. So just be careful. All right, so now I'd like to close with letting folks know about your role as an Aspen Institute Health Innovators Fellow. What's the goal of Aspen Institute and what have you been working on as a fellow?
Yeah, I love it. So I literally just got appointed and actually haven't started my fellowship yet. But what I'm excited about, what I'm really looking to use the Aspen Institute, what I'm learning from it, the network that I'm going to have from it, is to expand actually my work with the tour. I really want this to become, something that is eventually institutionalized, maybe somewhere with a strong partner, and just thinking about how the tour can be a leader in diversity in healthcare. That's my personal goal within the fellowship. But the Aspen Institute in general is about fostering leadership. So to get accepted as a fellow, you actually go through several sessions out in Aspen over a couple of years where you work with your cohort, your group, to really refine your project and to learn from each other and to focus on kind of the ideals of a good society and really being in kind of a thought-provoking space. So I love the idea of being part of a fellowship where I can think about innovation, where I can think about transformation. I love that, my career has turned to that, but now I have a personal space to really focus on that as well too. So I can't believe I got accepted into the Aspen Institute. So I'm just so excited. My first trip out there is actually like October 30th, like the day before Halloween.
Awesome.
Yeah, it's pretty cool.
I can believe you were accepted. So as can all of your friends, but I find a lot of my guests on my show have more humility than they should. But you do all the things. So you should never be surprised when you are accepted into something because,
No, it's pretty cool. And honestly, the class that I got accepted into, like it's that was more like, wow, these people have done a lot. I mean, yeah, I've done a great deal, but what's going to be amazing is to sit with these individuals for the next couple of years and get to know them and learn from them and hopefully, teach them something of my own. That's the best part of these sort of fellowships, these networking sort of opportunities. So yeah, professionally, there's a handful of them out there. There's like I have a couple of friends who've done presidential leadership, presidential library leadership or something. That's another one. Bunch of friends that have done White House fellowships and things like that. Like you get accepted into these programs for this kind of individual experience, but then you wind up with this network for growth that is just amazing. So I definitely recommend people look for as many of these opportunities as possible.
Yeah, I agree. I think, especially with the work that you've been doing, since we were in college, even with like, NAACP work back then, right? The kind of work that you are doing deserves a stage. And I think it is important for people to know all the things that you do, not just what you do in your day job. So I think it is a great opportunity, and they have benefited from having you even before you start.
I hope
So.
I hope so.
All right. So my last question, I like to do a lot of future predictions and, kind of give my guests a chance to say, like, if I had a magic wand or I could rub a genie, what would I do? So my question for you is, in your opinion, what would an equitable health system look like? And the follow-up to that is, universal healthcare automatically the solution, or you do have other ideas for a solution?
The second question is a little bit easier. I do believe in kind of a baseline of universality that we need to have in healthcare. I think everyone needs to have a primary care relationship. I think everyone should have the ability to prevent future illness. So, whether that's general, obviously public health education, so you understand nutrition and the importance of oral health and everything, so that we can prevent chronic disease long term. I definitely think at baseline, we need to set up that primary care structure. I definitely think we as well need to have these public programs to support more of the private industry that unfortunately does tend to have a financial tinge to their incentives. And so, I'm not necessarily in favor of a fully public option, because I do see the importance of kind of innovation like my company is doing. It's not as easily done, being that I came from government before this. That innovation is not as easily done when you're thinking of just a wholly government program. So I'm probably, in the middle there. I do believe in universal healthcare, but I don't think it's a single public option that we need to be leaning towards. I think for us to truly have health equity, we need more than just access. We need, I heard this, I totally stole this. We need the agency to actually use that access. So if you don't have the resources to, again, take off work, to be able to get to your doctor's appointment, to pay for the parking there, to understand what information they're sharing with you, to be able to pay for the meds even after, deductibles and co-payments and all the madness, the confusion of healthcare. If you don't have the ability to actually use the access that is given you, then it's all for naught. So for me, it's about making sure that there's increased agency for specific communities, and actually targeting what those resources are, and expanding it beyond just you get to see a doctor every once in a while. Like, it's got to go beyond medical care. It's got to focus on larger well-being. And so equity to me is not just access. It's about having the resources to be able to use that access.
Your agency comments reminds me of the COVID vaccines, and how, even though COVID vaccines were free, there were so many populations that were not vaccinated because they couldn't afford to take off work, or they couldn't risk getting sick from the COVID vaccine. And I think COVID just hammered home your point, right? It doesn't matter if you can't access healthcare because your livelihood is at risk from accessing healthcare.
There we go. That's exactly it.
Well, thank you so much for joining me today. Thank you all for tuning in to Getting Common. If you ever miss an episode, you can catch the rebroadcast anywhere podcasts are played, including Spotify and Apple Podcasts, and also on our Voice America website. We also have a YouTube channel that is called Getting Common. Feel free to email me through the show page or reach out on social media. I am at Carliss C on all platforms. Thank you again for listening, and thank you, Cameron, for joining me.
Thank you, Carliss. This is great.